Welcome, everyone. My name is Morgan Harrington, and I am the National Coordinator of Programs here at the American Liver Foundation. I'd like to be the first to welcome you today, and thank you for joining us for our Ask the Experts. Are you at risk for liver cancer? ALF's mission is to promote education, advocacy, support services, and research for the prevention, treatment, and cure of liver disease. As part of our commitment to the liver community, ALF offers a range of educational programs and resources for patients and providers. You can find more at www.liverfoundation.org. The program today is being delivered on the Zoom webinar platform and will be recorded and available on ALF's YouTube channel for future viewing. During today's presentation, please click on the Q&A feature if you have a question or a comment. We will make every effort to answer all questions towards the end of our program during the Q&A portion. Thank you to our sponsors, Merck, ISI, and Exelixis for their dedication, commitment, and support to the American Liver Foundation's Liver Cancer Series. We have a wonderful program for you today, and I am excited to share that we are joined by an amazing panel of physicians that will be introduced to you shortly. We are so appreciative they've been willing to take time out of their day to be here with us. For more information, please go to www.liverfoundation.org. Kick things off today, we're going to begin with a brief video featuring one of our patient volunteers. We are lucky to have Darryl here live with us today as well, and he will be sharing more of his story with us later in the event. Oh, let's see if we can get sound.
That hepatitis C can lay dormant in your body for up to 20 years without any symptoms. I asked the doctors, well, how do you get hepatitis? My doctor came back to me, she says, well, you say that you're in recovery during your years of use. Did you exchange needles? Well, no, I didn't exchange needles, so I knew that wasn't the case. And finally, they just wrapped it up, said, that way of life, when you have a lot of drugs you're exchanging, if you snort cocaine, exchanging dollars that's rolled up, just being in contact with a lot of people in that way. I had a feeling that liver cancer had developed because my body slowed down. My legs would cramp up, my arms would cramp up, my whole body would cramp up. Relatively speaking, the liver cancer was pretty simple to cure. 2 treatments and my liver cancer was taken care of. But at that time, my liver had been destroyed to the point we have to start talking about a transplant. At that time, I was a 56-year-old man, well-traveled. I'd been in the Navy for 10 years. I worked on cruise ships. I traveled around the world. But a transplant was totally new to me. When I got the liver transplant, man, life came back to me. I told one of my friends I'd known for a while that I'd had a liver transplant. Immediately, she came back to say, well, you don't even drink. Why do you need a liver transplant? And I knew that that's the stigma coming out. I felt many times that I was all alone, that I'm the only person in the world who's going through this. I can't tell you what it's like. You wouldn't understand. And in many cases, that's not really the case. And here today, 35 years clean, I'm living life beyond my wildest dreams. And I want people to know that you can get well. And by partnering with the American Liver Foundation, I get to tell my story. I get to assist other people. I get to be support for other people and let them know you can get well.
Now it is my pleasure to introduce the moderator of today's event, Dr. Bubu Banini. Dr. Banini is an assistant professor of medicine and digestive diseases at Yale University. She is the Translational Research Director for the Metabolic Health and Weight Management Program and Associate Director for the Yale Liver Center Clinical and Translational Core. Her clinical work with patients with obesity and liver disease link her to her research interest in fatty liver disease, alcohol-associated liver disease, liver cancer, and healthcare disparities. She has received funding for research from the National Cancer Institute and the National Institute on Alcohol Abuse and Alcoholism through career development programs, as well as the National Institute of Diabetes and Digestive and Kidney Diseases. We are thrilled to have her here with us today.
Thank you so much for that kind introduction, Morgan. It's my pleasure to be here. I want to thank everybody who has joined us today to hear about living with liver cancer. Today, we're going to speak about the prevalence of liver cancer, risk factors. We'll hear a little bit about chronic liver disease and how we can decrease our risk of getting liver disease and liver cancer. It's my pleasure to introduce our panelists for today. I want to introduce Dr. Olumide Gbolahan. He goes by Dr. Olu for short, who serves as an associate professor of medicine at the Department of Hematology and Oncology at the Emory University School of Medicine. Dr. Gbolahan specializes in the management of gastrointestinal and hepatobiliary malignancies. His research efforts are directed at drug development and translational work for hepatobiliary malignancies. Thank you for joining us, Dr. Gbolahan.
Thank you. Thank you very much for having me. And I have to thank Mr. Ellis for sharing his story. It's very inspiring, and it actually captures a lot of what I tell many of my people that I see, that when we're dealing with liver cancer, for most people, we're not just dealing with one disease, we're dealing with two different problems. We're dealing with the liver that's not working optimally, and then we're also now dealing with cancer. And sometimes we're able to manage one and we're not able to manage the other. But in this case, I'm very glad that for Mr. Ellis, he's able to get to the opportunity where he's able to manage the cancer, and he gets a transplant for the liver that's not working as well. So this is very good. I'm very happy to be part of this panel.
Absolutely. Thank you so much. And I look forward to speaking about some of the points you raised some more shortly. I would also like to introduce Dr. Lewis Roberts, who is the Peter and Francis Gorgeson Professor in Gastroenterology Cancer Research and consultant in gastroenterology and hepatology at the Mayo Clinic, where he is co-principal investigator of the Mayo Clinic Specialized Program of Research Excellence in Hepatobiliary Cancers. Dr. Roberts' research focuses on mechanisms of development of liver and biliary cancers, biomarkers for early detection of liver, biliary, and pancreas cancers, and prevention, diagnosis, and treatment of hepatitis and liver cancer. He has a particular interest in liver and biliary cancers in Africa, as well as in immigrant African and Asian communities in the United States. Dr. Roberts was unable to join us today. However, I was able to connect with him, and we pre-recorded a video that we'll be sharing with you shortly. In addition, I'd like to introduce Dr. Allison Martin, who was to join us as well today, however, is unable to do so due to a family emergency. Dr. Martin is an assistant professor of surgery at the Duke University School of Medicine and the Durham Veterans Affairs Medical Center. She serves as the Associate Program Director for the Complex General Surgical Oncology Fellowship at Duke. Dr. Martin's research centers on investigating health disparities in cancer surgery, with a particular focus on liver cancer and rural cancer equity. I know Dr. Martin was really looking forward to this session, and she sends her regrets. We are fortunate to be joined today by Dr. Darryl Ellis, whose video you just saw. Sorry, by Mr. Darryl Ellis, whose video you just saw, who is a double organ transplant recipient. A US Navy veteran, Darryl was diagnosed with hepatitis C in 2001, treated for liver cancer from 2010 to 2011, and later received a liver transplant after his condition worsened. His liver transplant was in 2015 and subsequently required a kidney transplant in 2016 after his kidneys failed during the liver transplant. Darryl credits these life-saving surgeries with greatly improving his quality of life. As an advocate for organ donation, Darryl volunteers with Donate Life NC, Live Share Carolinas, and the American Liver Foundation, focusing on increasing organ donation within the African American community. We know that African Americans are one of the groups in the most need for organs, but they are least likely to donate. And Darryl hopes to change that. He also works to inspire hope for transplant recipients. So thanks again to our audience for joining us today. We will go ahead by playing the video of my interview with Dr. Lewis Roberts. Good morning, Dr. Roberts.
Morning. It's a pleasure to meet.
Thank you for joining us today. So as you know, we are doing a session today on liver cancer with specific emphasis on Black or African American population. So we can get right in. I wanted to ask if you can speak a bit about how liver cancer develops and how it is diagnosed.
Thanks. And again, it's a pleasure to be here. And so liver cancer is a major cancer globally. It happens to be about the 5th most common cause of cancer across the world, but the 3rd most common cause of death from cancer. So it's actually one of the more lethal cancers. As you can see, more people proportionally are dying from it than actually have it. And how does liver cancer develop? It appears that the common theme for many types of liver cancer is related to two things, to inflammation of the liver. And so we find that conditions that cause liver inflammation make the liver more prone to development of cancer. So these, of course, include viral infections like viral hepatitis and hepatitis B and hepatitis C that cause chronic infection of the liver are the most common causes, with B being particularly the most common cause globally. But in addition, we have other conditions that can cause, for example, the deposition of fat in the liver. And you get fat in the liver, that fat can stimulate inflammation of the liver, and that can cause, again, the eventual development of liver cancer. And the two most common conditions then are diabetes and hypertension associated, what we call metabolic dysfunction associated steatotic liver disease, where you have fat that develops in the liver from the combination of diabetes, hypertension, and high cholesterol. And then we have alcoholic liver disease, where having a high alcohol intake in some people results in the development of fat in the liver, and that can also then lead to stimulate inflammation in the liver. The other major cause, and actually inflammation at one level it's one of the ways that inflammation causes liver cancer, is something that damages the DNA of the liver cells. So if you have liver cells and you have a toxin, for example, that they're exposed to, and we think particularly of dietary aflatoxins, these are from fungal contamination of food. They're toxins that are made that insert themselves into the DNA and damage the DNA. And in the case of chronic hepatitis B, we sometimes see liver cancer that develops without a lot of inflammation or a lot of scar tissue. And in those cases too, we see that hepatitis B, which is a DNA virus, can insert itself into the DNA of the person's liver. And that insertion can disrupt the DNA and make a person more likely to develop cancer of the liver. In terms of diagnosis, the liver is one of our major organs, and so it's protected by the body. It's on the right side of the abdomen, hidden underneath the ribs. So that makes it difficult to diagnose. It's not on the surface of your body, so you can easily see when there's a problem with it. And so typically, ideally, we diagnose liver cancer by identifying the people who are at risk for liver cancer and then doing some kind of a screening test using imaging like an ultrasound, or using a blood test to test to see if they have substances in their blood that are made by the liver cancer. One of the challenges there, of course, is that if you don't know that you have a disease or condition that puts you at risk, or that and you are therefore not receiving, the screening or surveillance for cancer, then you don't know you have a problem until the cancer gets big enough that it stretches the liver lining, it begins to cause pain, or it pushes out and gives you a big mass in your abdomen. And unfortunately, for many people, that's too late to have a diagnosis in order to get effective treatment.
Thank you so much. It definitely sounds like the a variety of mechanisms and risk factors, as you mentioned, and that the diagnosis also is quite complex. As you mentioned, if you don't know that you have those risk factors and you're predisposed, then you would not get surveillance to diagnose it. Can you speak a little bit about how incidence and mortality related to liver cancer may differ in Black populations compared to other populations?
Yes, I think particularly in the United States, we know that some of the conditions that are associated with risk of liver cancer can occur more frequently in Black populations. And so this applies, for example, to viral hepatitis, where we know that, for example, hepatitis C in many ways was more prevalent in some Black communities than in other communities. And then particularly among immigrant Africans, we tend to see high rates of hepatitis B as well. There may also be increased rates depending on the communities of metabolic dysfunction, associated liver disease, diabetes and hypertension, or of alcohol use as well. And interestingly, one of the things we know is that once people of African or Black individuals, African descent, develop liver cancer, they also have higher rates of death. There's about a 10% increased risk of death from liver cancer compared to individuals that are non-Hispanic white, for example. And so there seems to be some propensity for increased death. What is not clear is whether it's because of lack of access, for example, to the same quality of healthcare, whether it's lack of awareness of risk so that people aren't getting surveillance. But we know it definitely does impact Black individuals more than other communities.
So I think a bit of education would be helpful for patients or people to recognize potential risk for having chronic liver disease. Can you speak a little bit about what specifically these risks are, and when someone gets chronic liver disease, the different stages of chronic liver disease?
Yeah, so the key risk factors, as we discussed, are these conditions that cause inflammation in the liver, so chronic hepatitis B and chronic hepatitis C. So chronic hepatitis B, for example, is often transmitted from mother to child or in early life between members of a family. And then in adults, it can also be transmitted in unvaccinated adults through sexual transmission, through sharing of needles. And so it's first of all important in the case of hepatitis B that people have vaccination, at birth or in early life to prevent the risk of transmission. And then it's important that adults be tested for hepatitis B. There's recently, about a year ago, been a recommendation by the CDC that all adults in the United States should be tested for hepatitis B. For hepatitis C, there appears to have been a fair amount of transmission of hepatitis C in, particularly the individuals who were in the baby boomer generation from within the healthcare space from the use of incompletely sterilized needles or incompletely sterilized instruments, but also from injection drug use, from tattoos that people received. And more recently, there, of course, has been, with the opioid epidemic, a lot of drug use, and some of that intravenous drug use, and that drug use has also increased rates of hepatitis C in the United States. And again, the recommendation from the CDC is that all adults should be tested for hepatitis C so that people know they have it. There is curative treatment for hepatitis C. We can cure it. For hepatitis B, we can suppress the virus with drugs so that we reduce the risk of people developing long-term complications from it. Then we've mentioned already the metabolic dysfunction, which can occur from diabetes, from hypertension, from hyperlipidemia, high cholesterol, and also from alcohol use. So working to reduce all of those risk factors can definitely make a substantial difference to people's risk of cancer.
Great, thank you so much. Can you describe the different stages of chronic liver disease? And some of the people in our audience may have heard the term cirrhosis. Can you explain also cirrhosis and how that may contribute to liver cancer development?
Yeah, that's a great question, because we in medicine tend to like jargon almost, it seems, and we say these terms that are difficult for the average person to understand. And so cirrhosis really refers to the most advanced stages of scar tissue formation in the liver. So our liver is one of the organs that I tend to think of it as the factory of our body. It does a lot of the processing of food that comes from our intestines, all goes through the liver. It makes a lot of the important proteins in our body, helps with our blood clotting. It helps with keeping the fluid in our veins and arteries. So it's a big metabolic factory. Now, what happens in states where the liver is injured is that partly because it's exposed to lots of things that come through our body, the liver has this ability to replace itself or regenerate itself. And so, a toxin comes up, it damages some liver cells, the liver cells are destroyed, but new liver cells are formed. And that regenerative capacity is one of the reasons that we manage to survive so long in an adverse environment where we are exposed to toxins and other chemicals. But eventually, if we have something that damages the liver, such as chronic viral hepatitis, where you're infected by a virus that never goes away, it's destroying liver tissue, the liver repairs, and then there's more destruction. The liver repairs, there's more destruction. Eventually, the liver sort of wears out its ability to repair. And then just like on your skin, if you cut your skin in one place and it heals, you might never tell that you had a cut there. But if every week you cut in the same place, eventually you'll form a scar in there, because eventually the skin cannot repair itself evenly and it forms a scar. The same thing happens in your liver. Once you have all of this regeneration and you wear out your ability to regenerate, you have scar tissue that forms in the liver from all of the inflammation. And then that scar tissue begins to interfere with the function of the liver. And we have different stages of the scar tissue formation. So in the very earliest stages, when we can see just little whispers of scar tissue, we call it stage 1. And then, you get to the stage where between the different sections of the liver, we call them the different, it's like triads of the liver. Between these different sections, what we find is that the scar tissue is going across from one section to the other, from one group of blood vessels and bile ducts to the next. And so then we say there's bridging fibrosis. And eventually that bridging fibrosis gets to where then you have thick cords or thick bands of fibrosis that are surrounding the different sections of your liver. And eventually these, in a sense, it's almost like they strangle the liver cells, and you end up with this area of cirrhosis, where then you have areas that are nodules, that where the liver is trying to grow and push up against the bands of fibrosis. So that's when we have the most advanced stages that we call cirrhosis. And cirrhosis is associated then with, in a sense, it's like you're pumping blood that's coming from the intestines through the liver.
Thank
And when you
you
have all
so
this
much
scar tissue, the
for
blood can't
playing
go
that,
easily
Morgan.
through the
So,
liver. And
so
so then the
Dr.
pressure
Roberts
builds up.
very eloquently summarized the risk factors for chronic liver disease, progression of liver disease, and how liver cancer can potentially develop in that setting. I want to speak a little more about some of the major causes, risk factors for chronic liver disease that Dr. Roberts highlighted. For chronic viral hepatitis B and C, Dr. Olu, could you comment on measures that people can take to prevent contracting viral hepatitis?
Yeah, so we like to talk about viral hepatitis, particularly viral hepatitis C. For instance, in the baby boomer generation, a lot of good times were hard at that time. And, people sort of were, they don't know the things that we know. They probably didn't know the things that we know now, right? Around things like blood-based transmission of viral illnesses, right? So I think that this is an important thing to remember, that when there's bodily fluids, we don't know things that can be passed on. So it's very important to be careful around bodily fluids, both in the healthcare setting, at work, with tattooists, with people who are just potentially exchanging bodily fluids recreationally, right? So the important thing is for people who have to use needles, important to not share needles. And I think there are sort of like big public health programs in the works and that are being executed to exchange needles in all around the country. I think this is helpful. It will be helpful if the government and government agencies continue to adopt more of that. So being particular about sharing needles and thinking about it less as an individual, but more as a collective societal effort, I think that's helpful. The other for hepatitis C and potentially for being adults, the other mode of transmission is sexual practices. So trying to be cognizant of the persons that we are sharing bodily fluids with and using protection, I think that helps. I think finally, especially for hepatitis B, a big way of transmission is during parturition, so during pregnancy and parturition, so from the mother to the baby. I think for this, the push by the CDC to say that all adults should know their hepatitis B status, I think this is very helpful. That way, you know your hepatitis B status, and if you happen to have hepatitis B virus infection, then you can get treated. That will suppress the virus, and therefore that reduces the risk of transmission from mother, to child. And similarly for hepatitis C, we have treatments that work to eradicate hepatitis C. So again, this is not about stigma to a person. This is about the fact that there is a generation that didn't know what we know now. And that generation was exposed to hepatitis C. I don't think it matters how it happened. What is important is that we are where we are, and what can we do about it? What we can do about it is that we can eliminate hepatitis C. So know your hepatitis C status, and then let us get rid of hepatitis C in you.
Thank you. Thank you so much for those responses, Dr. Gbolahan. As we mentioned, we're really fortunate to have Darryl with us today as a person with lived experience with liver cancer. Darryl, is there anything that you would like to add to what has already been said regarding chronic viral hepatitis and liver cancer?
Yeah, I think just now, Dr. Olu, I think he stated it very well. Things are happening now that we know we didn't know at the time. My hepatitis C, I was diagnosed with hepatitis C just for going in for a health checkup. I wasn't sick. There was nothing wrong with me. It was time for a health checkup. I go for the health checkup. My doctor says, you have hepatitis C. And of course, I didn't believe the doctors when he told me because I wasn't sick. There was nothing wrong with me. I didn't feel bad. Um, but again, because we didn't know. And in fact, I'm military, former military, so I was going to the VA medical center. And at the time, this was 2001, the VA thought that hepatitis C was a post-Vietnam era problem for veterans because so many veterans were having hepatitis C that it became a required test with the VA. But then, of course, the CDC says, no, it's a baby boomer problem. Those born between 45 and 65, that it's a problem with them. And so with just awareness, but now that we have the awareness, I think that does a great deal for us and tells us how to deal with it. Again, I really didn't understand. But as soon as when I got my transplant, started doing presentations, someone from one of those presentations would always come to tell me, I have a friend who died from hepatitis C. I have a cousin who died from hepatitis C. So again, the awareness now.
Absolutely. Thank you so much for sharing that experience. Do you feel like there was some stigma associated with having hepatitis C, either at that time or from people that you've interacted with?
I think there was, yes, because basically, and I told my story here just now. When you say, how do you get it? That's one of the first questions that I ask. How do you get hepatitis C? And my doctor says, well, of course, comes from blood transfusions. And I knew that I hadn't had a blood transfusion. So then, well, using needles while you're using drugs, well, I didn't use needles. But as soon as he got to, do you roll up dollars and snort drugs, or do you pass straws around and snort drugs? And I think the stigma came from that the only way you got this disease was through the use of drugs. And I think the use of drugs for us personally, or for me personally, the use of drugs, because I kind of knew I was in the wrong as I'm using drugs here. But I was an addict. And here today, I can say I'm very proud to be a recovering person with 36 years of recovery. But at that time, when I was using drugs, I was using drugs. And again, I knew that I was wrong, but I couldn't stop it. And again, that stigma of being a drug user, that life you live as a drug user, that's the stigma.
Thank you. Thank you so much for sharing that, Darryl. And as Dr. Roberts had mentioned in the video, now with the opioid use, injection opioid use, unfortunately, we are seeing high cases of viral hepatitis C as well. At some point, we thought we got a good handle on it, but unfortunately, with the opioid crisis, that is rising as well. So definitely something that people should be aware of. So viral hepatitis B and C are a leading cause of liver cancer, as we've been discussing. Over the past decade, the entity metabolic dysfunction associated steatotic liver disease, or MASLD, commonly known as fatty liver disease, has also been increasing as a leading cause of liver cancer. Typically, MASLD is seen in persons with metabolic risk factors, including excess weight, type 2 diabetes, high blood pressure, or high cholesterol. And over time, that fat in the liver causes inflammation of the liver, injures the liver cells, and resulting in scarring of the liver. So for persons with MASLD, we recommend lifestyle interventions, including dietary modifications and increased physical activity geared at weight loss. There are also, fortunately, now a number of FDA-approved medications that can help patients to lose weight. And also earlier this year, we got our first drug approved that helps to improve scarring of the liver in the setting of mast cells. So that is exciting. But again, knowledge. It's good to be knowledgeable about your risk for chronic liver disease so that they can be addressed. Another major cause of chronic liver disease and liver cancer is alcohol. And we know that there are general recommendations made by the Food and Drug Administration for alcohol use. And essentially, they recommend no more than 1 drink a day for women and no more than 2 drinks a day for men. With patients who have some sort of underlying liver disease, we recommend complete avoidance of alcohol. Dr. Olu, can you comment on how someone may know that they're drinking too much alcohol?
Okay, so I'll answer that question. But if you don't mind, I would like to hear your opinion about medications that are now available to help people lose weight.
Yes.
The implications of that for reducing liver disease.
Absolutely.
And potentially, therefore, reducing the risk of liver cancer.
Mm-hmm.
And so that's one ask. Before I answer the question, I think I should also mention, I don't know that we have highlighted this properly. You know, for hepatitis B, we have a vaccine. So that's another reason, you know, why we should try to get to know what our status, so to speak, is. Because one, if you have hepatitis B, we can suppress the hepatitis B so that the risk of passing it on to somebody else is incredibly low. The risk of causing inflammation in your liver is lowered. And then more importantly, and also as important, if you don't have hepatitis B, then potentially we can give you a vaccine that reduces the risk of having hepatitis. So I think it's important to highlight that. And you had asked me and I didn't bring that up. Okay, so thank you.
Mm-hmm.
Yes, so how much alcohol is, can you rephrase the question?
Yeah.
I have very strong opinions about this.
Yeah, and we do want to hear your opinions. Yeah. So, you know, I mentioned that generally the recommendation is not more than 1 drink a day for women and not more than 2 for men. And a lot of times people go over these limits. Are there any things, you know, signs or symptoms or really telltale signs, behavioral signs that should clue someone in that they really are drinking too much if they go beyond these limits?
I think that where the data are today is that any alcohol is too much alcohol. I think that culturally it's a difficult message for us to deliver to ourselves and to the people we serve. But today, I don't know that we seriously think, for instance, that a little bit of red wine protects your heart by itself. We think that there's a lot of reasons why people who drink a little bit of red wine may be protected cardiovascularly. So a lot of the data is pointing to the fact that from a cardiovascular and cancer-related point of view, the safe amount of alcohol is no alcohol. However, we live in the world, so and we have to deal with the world as it is sometimes, and hence the recommendations that we have. Okay. However, when one begins to have problems around their relationships with others, with family members, with work, we don't even want it to get to a point where because of alcohol, you're having problems with the Lord. That's too extreme. But I think that once you get to a point where you're beginning to have problems with your relationships with people around you because of alcohol, I think that's a good time to check to see, you know, what life one wants for one's self. And I would like to pull Mr. Ellis in here if you don't mind. You know, there is the you know, Mr. Ellis has said that he was using drugs and he knew it was a bad thing. and he was doing it. I think that's for a long time. We know that people are not able to help themselves. I don't know that it's helpful to, pass that judgment in that way, right? That it's a wrong or it's a bad thing. It's what it is. But I think that when we get to a point where we're beginning to have these problems with people who are close to us, when we're having this problem with ourselves also, with the voice inside us that's telling us that maybe this is too much, I think that's the time to stop. This is my very long-winded answer to your very direct question.
Great. Thank you. Thank you for that insight. Any comments, Mr. Darryl?
No, I think is absolutely right. Because you do know when you're having problems, and you do know when you're having trouble in your relationships that, okay, it's time. But also there's sometimes we need to go a little bit further to get assistance with that. And lots of times we don't take that step to go further to get the assistance.
Absolutely. I totally agree. And what I suggest to my patients is that if there's something you're struggling with, you really should let other people around you know those struggles. I know a lot of times we keep it to ourselves, we want to hide it. But if it's something that we really are working on, having other people around us know is a lot of times is helpful, because when they see you, they're going to ask about it. They're going to say, how's that coming along? And sometimes that really is motivational to work on that habit, whether it's smoking or alcohol use or drug use. It's good to have your spouse know, your friends know, your pastor know, because you have that community to support you through that process. Dr. Olu asked about me commenting on the drugs that are available for weight loss. Is that correct? Yes. So there are several drugs that are out, that we can prescribe to patients to help with weight loss. The more recently approved ones are injection medications, which are quite effective and typically give the order of somewhere between 10 and 20% weight loss from baseline. Of course, everybody is different, and some people lose more than that. But it's essential to combine those medications also with lifestyle changes. We know that increased physical activity, really working on your diet to decrease your calorie consumption, eating healthier foods, having a plate that has a lot of lean proteins and vegetables are beneficial in several ways, and also contribute to weight loss in addition to the medication and increased physical activity. Usually we recommend aiming for about 30 to 60 minutes of moderate intensity exercise 5 times a week. So whether it's walking, brisk walking, you don't have to have a gym membership to exercise. You can go out and walk in the park, walk in the field, or walk in the wall. And all those are really beneficial in terms of lifestyle, decreasing your weight and helping with metabolic associated fatty liver disease if you've developed that. So thank you for the discussion so far. This has been great. So just to summarize what we have been talking about so far, we know that there's a number of risk factors that lead to chronic liver disease, typically viral hepatitis B and C, metabolic dysfunction associated steatotic liver disease, alcohol, as well as other less common risk factors. So these can lead to chronic liver disease, and in that setting, liver cancer can then develop. We've also heard about ways potentially to decrease our risk for liver disease. I'd like now to talk a bit about the different treatment modalities that are available for liver cancer. Dr. Olu, could you comment on those modalities?
Yeah, so, it's never good news to have cancer. I don't think there's any other way to look at it. When we hear about the big C, it's never good news. It doesn't sit down well with any of us. But in all of this, there is still good news. The good news being that for a good number of our people who have liver cancer, we can cure them of their liver cancer. So the treatment modalities there's a variety of treatment modalities depending on how early we catch this liver cancer. So So there's the very early liver cancer where you have a one tumor in the setting of a liver that's working well. This liver tumor is very small, and because it is very small and the rest of the liver is still good, then it's not very difficult for a surgeon to go and remove that tumor. They can either remove it by cutting it out, or they can remove it by burning it out. So we have surgery and we have ablation. So those are options for treating very early liver cancer. Okay. Then there are situations where you also have early liver cancers, but the liver itself is not healthy. So the liver is not healthy, the liver has cirrhosis, the liver is not functioning at capacity, so that even though the tumor is small, if you go and remove that tumor, there's a chance that the remaining liver will not be able to function to keep the person alive. Okay, so in those situations, we say there's a small tumor, but the liver is not healthy. So why don't we just take out the whole liver and replace that liver? Which is what happens when we offer people liver transplants. Okay, so that's another option. So one option, very small surgery, another option, a big surgery, which involves removing the liver. And for these two situations, in about 70%, 80% of people, depending on how early and how extensive the surgery is, we can get rid of the cancer. Okay. Now we have the intermediate stage of cancer, where there is a bunch of tumors all over the tumor. There's so much tumor that we really, really cannot go and do surgery to remove these tumors. So luckily, we know that the liver has two big blood supplies. So fun fact, the liver is an organ that has two blood supplies. Every other organ has one blood supply and one outflow. So because the liver has two inflows, and we know that liver tumors use only one of those inflows, right? We can direct treatment through that inflow to the tumor specifically. So we call this liver-directed treatments through an artery that supplies the tumors. So it can be in form of beads that block the blood supply to the tumors. Sometimes these beads are impregnated by chemotherapy, and the chemotherapy is released slowly to the tumors that are present in many parts of the liver. And then the other times it may be radiation beads that are infused to the tumor through this inflow artery to the liver tumors. So for intermediate stage tumors, we usually treat with local and regional therapy with intra-arterial chemotherapy or radiation. Okay, so we've talked about surgery, we've talked about transplant, we've talked about regional therapy through the blood vessel that supplies the tumors. Where I usually see people, and I really hope that less people come to see me, is when there's bad cancer to the point where we know that we cannot make this cancer go away. And everything we do is to keep the cancer at bay so that the person who has the cancer can live as long as possible with a good quality of life. So this is advanced cancer. This may be cancer that is so large that it is penetrating into blood vessels. It may be that the cancer is so widespread, it has gone to other organs, for instance, the bone or the lungs or lymph nodes far away from the liver. So we know that there's not much we can do to get rid of the liver or of the cancer. But as opposed to, say, 5 years ago, we can treat even this cancer better than before. Our treatment, we do not use chemotherapy for this cancer, even though I like to introduce myself as a chemotherapy doctor. But for advanced liver cancer, we don't use chemotherapy. Today, for most people, we will treat them with immunotherapy. These are intravenous IV medications that we give sometimes every 3 weeks, sometimes every 4 weeks. We give it, goes into your bloodstream all over the body, wakes up your immune system. Then the immune system that's woken up fights the cancer. this is the sort of like the standard of care for where we are with advanced treatment. The good news is that this has helped basically change the face of advanced cancer. So what was potentially a death sentence 5-6 years ago, we're maybe hopefully turning into a chronic disease. So these are all the options, and we still mix and match these options for the individual patient.
Thank you. Thank you so much for that information. So towards the end, I think you started to go a little bit into, newer therapies. And so I want to follow up on that and ask if you can share some of the therapies currently being researched.
Yeah, so for advanced cancer, most of our treatments today are based on immunotherapy. So it's basically trying to figure out how to make immunotherapy even work better. So we know that even though this immunotherapy, so for instance, the old standard of treatment was pills that we would give people. These pills will block new blood vessel formation in the tumor, so the tumor doesn't get new blood vessel, and therefore the tumor dies. With immunotherapy, we're able to almost double survival compared with the pills. So that's good. So we're now in a situation where up to 25% of people who have advanced liver cancer can be alive at 5 years because of immunotherapy, versus previously it was with the pill, we would be lucky if it was up to 8%, right? So that has been a good improvement. So it's now about what else can we do to this immunotherapy to help immunotherapy work better. A lot of this is based on new generations of immunotherapy. So that's one area in research. We have multiple phase 3 trials that are looking into that. I think another exciting field is in the field of, for those who have intermediate stage disease. So these are the people where, say, we go put either beads or chemotherapy beads or radiation beads that go to the liver. We have research efforts looking at combining what we think is the best treatment for advanced disease, which is immunotherapy, with some of these transarterial treatment options, both transarterial chemotherapy and transarterial radiation. We think that because this is early stage, which we're not able to cure, if we are able to control this thing with the regional therapies, we add immunotherapy on top of that, maybe we would even improve survival even further. So we're trying to play around a little bit with the immunotherapy to see how best we can use it across the spectrum of HCC. So from early stage to late stage. And some people are even beginning to think about this, even for people who may need a transplant. But I think that's still a little bit early.
Great. Thank you so much for that. So I know we have about 4 minutes to wrap up today's session. We do have a couple of questions from our audience, and I incorporated some of them into your responses. I want us to spend the last few minutes just giving some takeaway messages to our audience. Maybe if we could each just take 1 minute and leave hopefully uplifting parting message with our audience today about what we've discussed.
If I could, I'd like to start, please. Excuse me, that was a question there. Someone asked, what is the reception that I get when I share my story? Are people, are they open to getting screened, getting checked? And I like to say, yes, they are. Because one of the things is that we don't know, but as soon as we find out, as soon as we know that there are possibilities of something, then yes, we go get screened. Also, my story is a success story, thank God. And when people see successful stories, then they believe. So then they want to follow that path. So yes, it's very helpful when people hear my story and they do follow.
Thank you. Thank you so much, Darryl.
Yeah, so thank you very much for sharing, Mr. Ellis. I think it's also important. I think awareness is key. I think there are many ways to go about it. Awareness about screening is something that we need to do better at. We're screening less than 10% of people that need to be screened regularly. So I think there's an opportunity there. The opportunity will be taking more when people meet with somebody like Mr. Ellis, when people have the opportunity to connect more with a foundation like the American Liver Foundation. I hope to not be seeing so many people in my own clinic. I think that if, however, people come to my clinic, we're in a different place today than we were 5 years ago. And we're going to be in a different place in 2 years than we are today. This is for sure. Things will get better. There's always a fear around new problems. But if we come together, we can solve many problems.
Thank you. Thank you so much, Dr. Olu and Darryl. And I also want to thank Dr. Lewis Roberts for the interview that I shared earlier, and Dr. Allison Martin, who I know was not able to join today, but she was very excited, like I said earlier. So I know many of you may have heard the phrase knowledge is power, meaning that having knowledge is essentially a powerful tool that one possesses. By listening to this webinar today, I hope that we have helped improve your knowledge related to the risk factors for chronic liver disease, how liver disease progresses, and how you might decrease your risk for getting chronic liver disease that potentially could develop into liver cancer. I also hope that this knowledge will empower you to make informed decisions as to how best to care for your liver. I wish you good health and happy holidays in advance.
Thank you so much, Dr. Banini, Dr. Olu, and Darryl. We just appreciate you all being a part of the American Liver Foundation and supporting this series. Have a great night, everyone.
Thank you so much.
Thank you.
Thank you.